Hey guys, welcome to my channel. Today we are going to discuss about the clinical aspects of this long bone of arm. Before going to explore this, please subscribe to my channel. Now coming to this, the long bone of arm, this is a humerus. Now what are the clinical aspects usually we can find? So I'm not going to teach all the clinical aspects, rather I'm going to teach only few clinical aspects which are helpful in your examinations. Now let us discuss about the long bone of arm. First I will explain the upper end, then I will go for the shaft. After that I will go into explain about the lower end of humerus. Now let us see, this is the head of the humerus. Head, as you all know, that it is going to articulate with the glenoid cavity of the scapula, forms the glenohumeral joint. In the hyperabduction of your shoulder, and if you're hanging for a long time, what usually happens is subglenoid dislocation may happen. Subglenoid dislocation. So when you're over hanging, or also when you're pulling of the hands, pulling of the upper limbs, so that causes the subglenoid dislocation. Then we'll coming down and try to see the surgical neck of the humerus. So surgical neck, which is present between the upper end and the shaft. Surgical neck is encircled by axillary nerve and the posterior circumflex humeral artery, which is encircling from the posterior aspect. From anterior aspect, you can identify anterior circumflex humeral artery. So these two arteries are encircling the surgical neck along with the axillary nerve. So common site for the fractures of upper end is at the surgical neck. That's why it is called as surgical neck. So that causes the fracture of the surgical neck, causes the damage of axillary nerve. Let us come down. Yeah. So we have discussed about the fractures of surgical neck of humerus. So what usually happens during the damage of axillary nerve, as axillary nerve is encircling the surgical neck of humerus. So loss of abduction can be seen. Loss of abduction can be seen, and also the shoulder joint, flexion of shoulder joint is also going to become lost. And as you all know that there is a cutaneous nerve which is coming from the axillary nerve. There is upper lateral cutaneous nerve of arm. So the loss of sensation can be seen at the upper part of the arm, upper lateral aspect of the arm. So that is about the condition of the damage of axillary nerve. Now try to see the shaft of humerus. Now shaft of humerus, when you try to see the posterior surface of shaft of humerus, what we can identify is there is a radial groove or a spiral groove which is lodging the radial nerve along with the profunda brachii artery. So the fractures of the shaft of humerus causes the damage of radial nerve. What happens during the damage of radial nerve at the fracture of shaft of humerus? As I told you earlier, shaft of humerus, posterior surface of shaft of humerus, it is lodging radial nerve along with the profunda brachii artery. So the radial nerve, before it enters into the radial groove or spiral groove which is present on the posterior surface of shaft of humerus, so first the branch which is coming and it is going to supply to the long head of triceps. Then after enters into the spiral groove, it is going to supply to the medial head of triceps brachii. Then in the radial groove, when it is in the radial groove, it is going to supply to the lateral head of triceps brachii. Now during the fracture of shaft of humerus, that causes the damage of radial nerve. What are the complications can be seen? What are the complications? So from the radial nerve, first cutaneous nerve which is coming here is lower lateral cutaneous nerve. So the lower lateral cutaneous nerve which is going to supply to the lower aspect of the arm, lower skin of the lower aspect of the arm. So sensation over the lower aspect of the arm, lateral aspect of the arm is lost. Then after that, there is the same nerve. There is a nerve which is passing through the radial groove. So that is piercing the lateral intermuscular septa. Then it is passing through the extensor. So the extension is going to become lost. So what happens? There is a wrist drop can be seen. A wrist drop can be seen, and also we can identify the loss of sensation of the dorsum of the hand and to the fingers, and also to the extensor compartment of the forearm. So skin of the extensor compartment of the forearm, that is going to become lost. So that is about the damage of radial nerve. Now let us come down, try to see here the lower part. lower part, the supracondylar fractures. This is very important, supracondylar fractures. So supracondylar fractures, these are the two condyles, medial epicondyle and then lateral epicondyle. So above these two condyles, you can identify this is the supracondylar fractures. Sometimes, there might be the fracture between the supracondylar fractures causes the two segments can be formed, upper segment and the lower segment. It's also called as proximal segment and the distal segment. So what usually happens is this proximal segment, it goes anteriorly in the fractures of the supracondyles. So the proximal segment which goes anteriorly, the distal segment which goes posteriorly. Distal segment, it goes posteriorly. So this is how we can identify. Then what usually happens is, as we have discussed the triangle of isosceles in our previous class. So what is the triangle of isosceles? So I have told you that, so the lateral epicondyle, then we can identify the posterior margin of superior surface of olecranon process of ulna, and then medial epicondyle. These three are in the same plane in the extension. When try to see, this is the flexion. When flexion happens, what usually happens is there is a triangular area, triangular space can be formed. So between the medial epicondyle, lateral epicondyle, and this is the posterior end of superior surface of olecranon process. So this is called as triangle of isosceles. So in the fractures, in the supracondylar fractures, there is no disturbance in the triangle of isosceles. Rather, in the dislocation of elbow, there then you can identify the disturbance of triangle of isosceles. Disturbance of triangle of isosceles can be seen in the dislocation of elbow. That is about the dislocation and the supracondylar fractures differences. Now, other supracondylar fractures, in the supracondylar fractures, the fractured bony part, the proximal fractured bony part, it also compresses the brachial artery. That causes Volkmann's ischemic contracture. Now coming to this, what happens during the damage or the compression of brachial artery. As I told you earlier, so in the supracondylar fractures, the proximal segment, it is moving forwards and is going to compress the brachial artery. That leads to the loss of blood supply to the forearm and the hand. So that type of condition called as Volkmann's ischemic contracture. That is about the clinical aspects. Other things what we can identify is, sometimes you can identify there is a small tubercle at the medial supracondylar ridge, and from this medial supracondylar ridge to this medial epicondyle, there is a ligament called as a ligament of Struthers. So what usually happens in the ligament of Struthers is, so sometimes the median nerve and the brachial artery, they may be compressed by this ligament. And here the ligament of Struthers, that is also, it may compresses the median nerve or it may compresses the brachial artery. So there are two areas, there might be possibilities of the compression of the brachial artery. One is ligament of Struthers, sometimes only you can identify, but in the fractures of the supracondylar fractures, probably you can see that compression of brachial artery, or it may damage the brachial artery. So what usually happens in the Volkmann's ischemic contracture is, remember 5 P's. 5P. What is a P? So all the symptoms, they starts with a P. One is puffiness. The lower, the forearm and the hand, they enlarge, swells. The puffiness can be seen. The next one is pallor. The decoloration of the forearm and the hand can be seen, pallor. The third one is pain. Pain can be seen. So we can find that there is a pain in the forearm and also in the hand. Then we can identify there is a pulselessness. Fourth one is pulselessness. The feeling, the radial arterial pulse, we cannot feel that radial arterial pulse more. So the pulse will be very less. Pulse is less. Then last piece, obviously when you have all the symptoms, the ultimate symptom is paralysis. Paralysis of these muscles, so forearm muscles and then hand muscles. So what usually happens is the flexion of wrist can be seen. The Volkmann's ischemic contracture, what usually happens is the person can flex his wrist, then the extension of the metacarpophalangeal joint and the flexion of interphalangeal joint. Flexion of interphalangeal joint, extension of metacarpophalangeal joint, and flexion of wrist can be seen. So that is the condition, that is the symptoms can be seen in the Volkmann's ischemic contracture. And these are the few clinical aspects which we can identify in the humerus. Okay. So other clinical aspect what we can identify is behind the medial epicondyle. Behind the medial epicondyle, you can identify there is a small groove that is lodging the ulnar nerve. Ulnar nerve is passing through this groove and enters into the forearm between the two heads of flexor carpi ulnaris. So in the fractures of medial epicondyle, fractures of the medial epicondyle, you may see the compression of ulnar nerve can be seen. Compression of ulnar nerve, and sometimes the fibrous tunnel can be seen that. So the fibrous part, it compresses the ulnar nerve behind the medial epicondyle. So these are the clinical aspects which we can identify at the lower end of humerus. Thank you. See you soon with a new class.